And that's exactly what I've been alluding to when I'm talking about melding these paradigms. Yes, I do see that. I see that probably being the way real-world use will be quite frequently.
There have been more insights into this sort of induction maintenance paradigm, like Patina, including here at San Antonio. There's the trial using curated.
Yeah, the HER2 climate trial, right?
What's your take on that? Can you see yourself thinking about that?
I do, and I do. And as I was watching the data presented, I found myself scribbling what I was going to do for an ER positive versus an ER negative.
Right.
And again, I am overwhelmed by the notion of what the progression-free survival for these patients could be if you start to, again, we're now melding, right? We're blending trials and data because we really aren't going to have maintenance data for this paradigm anytime soon, if at all. Hopefully we will at all. Yes, very enthusiastic about it. For example,
Specifically for the hormone receptor negative group?
So the hormone receptor negative group, let's think about that, right? So like tucatinib is a drug that, it's really easy to dose modify if needed if somebody does have, for example, diarrhea or hepatotoxicity, and usually a patient could feel quite well on that. In fact, usually when we use tucatinib and we combine it with capecitabine, the capecitabine is the toxicity driver.
That's true.
And so I don't worry about that. I mean, certainly we have a cost issue. We're layering very expensive drugs on very expensive drugs. So that's one discussion. But you've got a drug that can decrease central nervous system events, is
Right.
usually going to be able to be used without quality of life deficit and can prolong that maintenance period. That excites me. It does.
Okay.
Yeah.
And what about tolerability? What do you think of the safety on HER2
I felt very comfortable with that. Again, assuming nobody's pushing the dose. If somebody's having GI toxicity on tucatinib, like you can't ask that of somebody for years when
Exactly.
you could bring a dose down.
Right.
I mean, can I ask how you felt about the maintenance data and how you think about it?
Well, I think it might be a consideration for selected patients who may not be candidates for antibody-drug conjugate first-line treatment, that they could consider this as a, induction maintenance strategy for the hormone receptor negative groups. The hormone receptor positive, I think I'm frankly probably more excited about the Patina approach because the synergism between CDK4/6 inhibitors and anti-HER2 agents. So that's kind of my take. But I think for the vast majority of patients, I'm going to be talking about desiprestone now.
Oh, for sure. For sure.
There's also the Inavo 122 trial, which is induction maintenance with a maintenance of inavolisib for infected ischemia, which we saw 30% in the DB09 trial, as we mentioned. So that's another ongoing strategy that we'll get data from probably next year. What are your kind of final takes then on the induction maintenance versus DB09 with an ADC pertuzumab doublet up front? And could you envision a future where maybe for selected patients, let's say the hormone receptor positive subset, could you do a DB09 induction followed by a Patina maintenance?
Yeah, and that's
future.
Yeah, and that's what and that's exactly what I've been alluding to when I'm talking about melding these paradigms. Yes, I do see that. I see that probably being the way real-world use will be quite frequently. However, having said that, many patients tolerate T-DXd very well. And if somebody's doing extremely well, once you started the DB09 regimen, you could also argue why change it. So maybe that's not the patient you're pushing for maintenance on.
I see.
Why rock that boat? So I really think that these are going to be, clearly we agree that Desiprestone regimen is unbelievably exceptional and will be what we prefer to start with. But where the art of taking a patient through those months and years after, I think that's going to be a lot to bear. Yeah.